So again, this is being recorded if you can't make it or if you didn't miss part of it, and also for your peers, if other people in your practice need to view this, we can do this. This is our oversight board that met earlier this week. The main thing on their agenda was talking about funds flow distribution. Again, being optimistic and proactive, hopefully if and when we do get distributions, how that money should work, coming back to you as the practices. Just for review, in 2023, in order to be eligible for shared savings and fund flow, you do need to submit your quality report. As you know, we, on behalf of each of the member practices, submit your MIPS. You can see in 2023, our scores were generally better. We do have some initiatives in place and going through for 2024 as well to make that even better in that. The bar or the hurdle, you do have to have sufficient quality to participate in shared savings. If we were not to submit anything, then of course we would not be eligible. We did more than surpass the threshold needed, and in 2022 as well as 2023 there, and we're looking to improve those scores even more going forward. As you know, and you can see from the website, and each of you received your performance within the network in terms of a scatter plot as well as in the supporting data behind it. This is the driving metric for the performance evaluation going forward. Again, there's the statistics behind it. This is blinded, all the different, and this is only as of the first quarter of 2024. We do not have second quarter yet from CMS. They did not share that. We also talked about a fraud event in 2023, which at our last meeting, we did not know what CMS was going to do with that. Many of you may know that earlier this month, in early July, CMS did acknowledge widespread fraud involving urinary catheters across all ACOs. And their solution to that was to eliminate that cost from every ACO. That's generally very favorable, and that's good for us, especially because you could see in 2023, we had almost $2 million of this probable fraud going on in our own network. So $2 million of our spend will be removed for the performance year 2023. What offsets that, though, is now the benchmarks are going to reset entirely too for 2023. So again, we've always been very close to the benchmark. With the elimination of the spend, that's a good thing for us. Resetting of the benchmark is not a good thing for us. We're going to see, hopefully, the catheter spend more than offsets the benchmark adjustment, which will result in a shared savings for us and for you. The committees that work for the PACN and for the ACO include credentialing, contracting, quality, oversight, group purchasing, and in particular today we're talking about funds flow and the methodology of the funds distribution, how they go about that. For the performance year 2023, as you know, half of the payment is based on participation, meaning the number of Medicare members you have enrolled, and half of it is based on performance, and that's that scatterplot graph and data that we showed before. How much risk-adjusted money or surplus savings your practice brings into the network, that proportion will determine that one. There are other potential scoring metrics that are going to be implemented going forward for performance year 2024 that we're in right now, and that's going to be the basis of our discussion today, and that's what the ACO Oversight Board decided in there. So just for review and for example, and certainly questions welcome after explanation, I'm going to say, we're going to assume just for simple math that we have a network of 10 practices and 100 Medicare lives. Within the 10 practices, some practices have 2 members, some practices have 20 members. These are your fee-for-service only Medicare members in the ACO, in the Medicare Shared Savings Program, or MSSP, that we're talking about. And let's say, after all is said and done, after CMS calculations, $10,000 is coming back to our PACN practices We've shared money for the government. We've passed our threshold. And after CMS and other calculations take their cut, $10,000 come back to us. 7 practices were in the green, meaning they saved money and they brought that. 3 of the practices had net losses, meaning that the expenses for their patients actually exceeded the benchmark and they did not bring in any revenue. Of the 7 practices that brought it in, it ranged from $250 to $2,500. Again, these are just illustrative numbers to help with the calculation and to show it. But $10,000 was saved, and practices, some of them brought in $2,500, some of them brought in less, and some in between. So for practice Y, which is a member of the network, one of the 10 practices, they have 15 Medicare members, and they actually saved $2,000 for the illustration. So for their participation or attribution portion allocation for the ACO, we're going to split it 50-50. So out of the $10,000, $5,000 goes towards attribution for the network and $5,000 goes towards performance. Out of the $5,000 for attribution, they had 15 of our 100 lives, or 15%. They get 15% of the $5,000, or $750 for participation. Similarly, for performance, they brought in $2,000 there. $2,000 out of the $10,000 savings is 20%. 20% of the $5,000 allocated for performance measures is $1,000. Practice Y would get a total of $1,000 for performance, $750 for participation, or a total of $1,750 for that performance year. I'll pause right there, make sure there's no questions, and then we'll go on to the new possible metrics being applied there. So there was recognition by the ACO board that just attribution and just performance in itself may not capture all the good work and the hard work that your practice is doing. And even a practice that is engaged and doing everything quote unquote right could have a loss in performance due to unexpected high-cost patients. Again, if you have a small number of patients in the network, 1 or 2 of them have a catastrophic year where they're in a car accident, they need a fall and a hip replacement, and maybe hospitalized with an ICU stay. Even though you've done all your annual wellness visit and preventive care, they still may end up in a loss. So additional opportunities for performance recognition and evaluation was recommended by the board, and they emphasized that it should be objective, measurable, publicized. They incentivize best practice. It rewards engagement and participation, and it's defensible. So if there was a question, you'll be able to answer how you got to that. They came up with 9 performance metrics for 2024. The ones shaded in the bottom, the peach ones, are not quite ready for prime time. So they will be in place and evaluated, but they're not going to count towards the monetary distribution. So out of the performance side, moving forward in 2024, performance now would be weighted a little bit higher at 60%, and the participation or the attribution would be weighted at 40%. Now, participation can never be discounted. Your total covered lives are always important, and this is a long game, meaning that year on year, we need to appreciate how we evolve there. So a practice that is in the positive or savings one year could be a loss the next year, and still a very good and a high performing practice, and then back to being savings and even higher savings in subsequent years. So just being in the game and participation is critical and has a significant weight going forward, and that's 40%. Now, out of the performance, the financial performance we talked about, again, will be the majority of what drives that. So your risk-adjusted surplus would count for 80% of the performance metric. Your responses to the outreach of our PA Clinical Network clinical team, emails, phone calls, etc., would count for 10% of the weight. Your attendance in meetings such as this, like this ACO forum, would be 5%. Your access and permission to your EMR is critical for us to be able to help guide and unobtrusively support your practice going forward. So that's 2%. Citizenship credit, meaning that many of you participate in committees, many of you could serve in certain roles. That would give you up to 2% addition. And loyalty. Most of you have been with us in the network since inception and year one. So you would get, for every year, you would get a loyalty credit going forward with that. And that's 1%. Again, not a lot, but it recognizes. And in future years, the board may increase the weights of some of these. And like we said, the bottom ones, once they're tested and proven, and we can make sure that they are objective and reproducible, they may carry some weight in the process as well. All of that totals 100%. So going back and going forward, underperformance, there'll be some other criteria that will allow you to earn performance money in that going forward with that. And again, this will be shared with you not only on the website, but we'll put this out in a newsletter so you're aware of that going forward. So I'll just stop right there. And that was a lot very quickly, but it is important. And it's, you know, good care is at the heart of everything we're doing, but recognizing that good care and recognizing it monetarily is kind of where the meat of our ACO is, and making sure that it's transparent, understood, and we get it right is key. So again, I'll pause and allow any questions, and I'll also allow Wendy and her team, which have been very helpful in helping think through this and helping the board come to these decisions. I say the weights or the percentages are not written in stone yet. The board is going to weigh in and finalize those, but this is approximately where we're headed, and we didn't want to delay notification, especially because in this 2024 year, there's going to be these opportunities still to earn this. And again, these meetings are recorded. So things like this, even if you missed meetings earlier this year, you can sign in, you can view it, and we'll have recognition of that, and that would count towards that meeting attendance. Wendy, anything you want to add? Anything I did not clearly emphasize?
Yeah, no, I think you did a great job. I know we did, as a quality team, struggled with getting this out there, because we want to make sure that it's measurable and that it's objective. Some of it doesn't, so we want to make sure we have the right measures in place for tracking as well. And that's why some of these are not ready for prime time, because tracking it might be more of more problematic or more complicated. A lot of these measures you are already doing, and it's already kind of a given. But for some practices that don't, or as Dr. Pagan mentioned, some of the practices that do not end up with a surplus, or that have some higher cost patients for that year, this still enables you to get some shared savings if we hit as a network. So just trying to look at all angles and follow what the board is kind of directing us to do as well.
Great. So we'll publicize this. We'll circulate it. We'll let you know the board's final decisions in terms of the percentages. But I think it provides increased opportunities, in addition to the overall shared savings, to be recognized for good performance in that. And overall, all of these will help your practice as well as the overall network achieve, like we said, that year-on-year success going forward. Other things we talked about before, again, this is more of review, just to make sure that there, and it's included in the recording there. What we're all about is using the data smartly, that you don't work harder, but we work wiser in the process. Again, one of the data points is the financial performance, as we talked about. Going forward for 2025, some changes. We will be entering into a more mature or an enhanced track of the MSSP. That allows for better flexibility in that benchmark or that target rate. And that's critical because we can almost assure then that we're going to hit shared savings every year. That comes with a downside exposure. You as a practice are not exposed though. If in the unlikely event that instead of saving money for Medicare, our ACO lost money, you would not be responsible for that. The PA Clinical Network absorbs that cost, and our partnership with Guide Health is helpful in that as well. So you have no personal downside exposure. It's upside only for our practices. But for the ACO year that we're going into, the enhanced track, we will be entering in something that does have downside exposure. We need to prove, again, not you, but we as a network have to prove a repayment mechanism to CMS in an event that does happen. PA Med, as our helpful partner, comes into play with that, and their financials serve as a backstop in this, as well as we said, Guide Health has assured us that if there was a loss, and again, Guide Health is so confident that their help will bring us to higher levels of savings, they're willing to assume this. They kind of put their money where their mouth is. They said, with our help, there's no way you're going to lose. We are again doing retrospective reconciliation. That means after the year is all said and done, CMS finalizes or calculates which patients were in our network and which patients weren't. We have, and thanks to Keith and his team in business development, we have about probably 8 new groups that are going to join us for the ACO for 2025, which is great. The more, the merrier. That application is still in process. CMS needs to approve those groups. And the next response, or we've gone through 2 phases so far towards that application. The next one is in the beginning of September 2025. By then, we should know for sure who's in and who's not with CMS's approval and the groups and our due diligence, making sure that everything fits correctly. There. Again, we talked about, there's a lot of information out there. We, as a network, try to make it very manageable and bite-sized for you. You've been getting patient lists. You've been getting ideas there. Remember, it doesn't take a lot. We've looked at it, about 5% of patients in your practice and 5% in our overall network make the difference between savings and losses. And again, this graph, you may remember, was one of many that showed within each of our groups, there's just a small amount of patients that make that determination and can turn a savings into a loss in that. So it doesn't take much in doing that. Data strategies that you know of, missing HCCs. There are a lot of diagnoses and codes used by your specialist consultants that need to be recaptured by them or you, since we don't have control over that, your practice. And again, recognizing all the complexities of the whole patient that you're caring of are important. Again, annual wellness visits are important. Your high utilizing, or the patients that tend to go to the hospital and use the emergency room, need attention. Patients that look like they're using a lot, but they don't look like they have a lot of risk, are also being highlighted. And in the next quarter, you'll be seeing attribution additions. So these are fairly straightforward patients that you've seen once or so in the past that need just one visit with you to be added officially with that retrospective reconciliation to our network. That will raise our benchmark. And again, if they're straightforward, they won't use a lot of cost. That's more shared savings to go around there. Again, over half of our patients are missing at least one HCC, and most of these are not from outside of our network. Coding is critical. We talked again about the big 5, meaning annual wellness visits, etc. All you need to do is the great care that you continue to do, it capture the whole patient, and coding. Guide Health is helpful now too, because they have coding analytics and support. So if you ever have questions about it, and proactively, they may be reaching out to you as well. Recall that a diagnosis, even if you're not treating in that visit, but you're considering in the overall milieu of the patient, and you know that they're following up with a cardiologist or GI or whoever, as long as you're monitoring and evaluating and documenting that, that can be added as a $0 code. In that there's two acronyms: MEET, monitor, evaluate, assess, and treat, or treat, assess, monitor, or medicate, plan, evaluate, or refer. Any one of those things will allow you to recognize that patient and their complexity. And again, it's always the same. We're blessed with your groups. We're blessed with the great care that you give. That's all you need to continue to doing is that great care. We just have to make sure that we have to capture that whole patient in the process of that care and code it accurately going forward. We talked about the one visit away patients with a straightforward history that you've seen before. That'll be the new parts of the bite-sized patient list that you'll be getting in the remainder of the year. There's a lot of tools out there to support you. Again, check the website, give us a call, let us know. You know, in addition to medical liability insurance, there's behavioral health services, there's other things. Guide Health is the newest. Most of you have heard of or are seeing Guide Health in the next several weeks as an introduction to your practice. So far, that's been going very well. Almost 2/3 of the target practices have been reached already. There's about a third going forward. And again, looking forward to your participation, because again, with the robust help of Guide Health, reaching out to your patients between visits as an extension of your office, as well as supporting you with coding and billing, we should be assured of success. Some of our practices are implementing Mindula for behavioral health. This has a little bit of a financial upside for you, but mostly it does help with care management and your workflow. Also, AVOCO, which has remote patient monitoring and chronic care management, has a financial upside for those patients as well. Keep an eye on the lab utilization. Again, hospitals cost about 3 to 5 times what it does in a generic lab. You can see here the breakdown in 2023 for our lab services. Tower Health, Geisinger, Wilkes-Barre, again, head the list in the cost of labs, and that could be savings that comes back to us. You know about the website. Feel free, if you're on social media, to give us a like and share things. Again, open for any questions, and look forward to all that you do.
Dr. Pagan, this is Janet.
Yes.
I get all this, and yet when I look at the number of people things that we cannot control, that are totally out of the primary care physician's control, too many ER visits, and of course, where we are, there really aren't many choices. It's pretty much Geisinger, and they are probably more expensive than some of the other, like in your neck of the woods. Any suggestions what we can do about that? Because we are held to the gaps, and we are asked to keep the costs down. But one hospitalization at Geisinger probably blows that right out of the water.
You're right, and again, where we can, that's the whole thing, is to try to influence what we can. So the main opportunity there is as you're talking about utilization and cost, we may not be able to bend the curve that much for those patients just yet. Now, as we get stronger as an ACO, and as we have more influence on where you refer to, if it's a specialist, so if there's a cardiologist that's not affiliated with Geisinger, that is good in your region, you know, you may think about giving them more business and less to Geisinger, because again, anybody in the Geisinger machine is going to use a lot of Geisinger services. But more importantly, for what you've just explained, there are things you can't control. Capturing the whole complexity of the patient becomes critical, because again, there's 2 parts to the savings. One is the allocation or the benchmark that CMS is providing for that patient, for all of your patients in your practice and all the patients in the ACO. So if the complexity of the patient is fully captured, that'll be a very high or a higher benchmark. The other you talked about is utilization and cost. Whatever you can save is the difference there. So where we can't control costs, we may be able to control or better capture the patient in their complexity. Certainly if they're getting hospitalized, they're in the ER, they're in the ICU, they've got some issues going on. We have to make sure that those are all captured in there. So CMS knows in their allocation, listen, this is a tough patient there. Now, CMS also has regional adjustments that should somewhat account for expensive areas versus non-expensive areas. It's not an exact science, but to your question, to the things that you can't really control, what you can control is the complete capture of that patient and making sure that it's accurately coded.
Well, now I have another question.
Go ahead.
So I like that little chart you had up there showing the more, for example, for lab work, the most expensive labs
Yep.
down to the least expensive. Do you have something like that for other services such as imaging? That's a visual that's very, it hits you.
Yep. And I think we are maturing in our data and our analytics. And we certainly have that capability. So I think your suggestion is a great one to break it down by imaging. Obviously there are very few freestanding radiology labs. And I know that, for some specialties like orthopedics, they may have their own imaging. There may be a breast center or something that has its own imaging, but we can look at that as well and produce a similar graphic to this one to show that.
I've seen
great suggestion, but in general, I think we know already anything going to the hospital is
Right.
going to be pretty expensive. Now, if you could, and again, I'm not saying this, but if you could see the patient, evaluate them, avoid the ER visit where that whole cascade of testing and imaging takes place, that's a cost savings opportunity.
Well, right now, one of the things we're experiencing, at least in our area, there's a lot of Aetna Medicare. And since Kaiser has taken over or purchased the Geisinger system, we're hearing that they are now contacting patients prior to something like an MRI or CAT scan and telling the patient, when you come, bring $800 because that's your share. So then we've got patients coming back to us and saying, I don't want to go for that CAT scan because I'm going to owe $800. They're not preferred for Aetna. So we've been, reaching out and finding other imaging facilities that we can send these patients to. But that's something new. We've been seeing a good bit of that over the last 4 or 5 months.
Well, thanks for sharing that. And again, that's actually one of the benefits of a network and an ACO is that you can share and we amongst ourselves can talk and say, I'm seeing this, I'm seeing that there, and we can make adjustments. What I do see also coming forward, and again, we're not really to the point yet, but where we will be is we'll be able to go down to Geisinger and say, listen, we can show them a similar graphic and say, listen, you cost more than any other hospital in our network. What can we do about that? Can you come to a special arrangement with PA Clinical Network patients where their beds are discounted X or Y, or their services or their Y, because our doctors are onto you and they are going to refer elsewhere. If you remain the most expensive, they are going to help their patients make the best choices for their care. And unfortunately, due to your cost, Geisinger may not be their best choice. So that is one of the powers or one of the benefits of an ACO is sharing that knowledge and intel, and then being able to kind of act accordingly. Exactly what you're doing, that you're hearing from your patients and you're steering them to other imaging choices in your area, knowing exactly who those choices are. And we could tell our other groups in your area too. That again is one of those benefits. Thank you. Thanks for sharing that. Thanks, everyone.